Hello everyone, welcome to our first online lecture at the RHN. Thank you for joining us. I just want to apologise in advance for any technical hitches. We've not done this before. Just to reassure any of you who've been asking, we will be recording this online lecture and it will be available on our website in a few days' time for anyone who misses it or any colleagues that you'd like to forward this on to. I'd just like to introduce my colleague Amy. Amy will be sharing some of her research. This is an ongoing PhD study. It's an assessment from Emergence of Prolonged Disorders of Consciousness. It's a current opinion in the UK practice, but she'll be able to expand on that further. Over to you, Amy.
Okay, hopefully you can all see the slides and hear me. Hold on a second. Anna, do you want to stop the door? Hopefully you can all see the slides and hear me. I was just getting a bit of feedback from Anna in the room next door. So my name's Amy and I'm a speech and language therapist at the Royal Hospital for Neurodisability down in London. Sorry guys, I can't. Oh, okay, so the Royal Hospital for Neurodisability, so we're a charity and we're independent from the NHS, but we work very closely with it to provide a service to patients with complex neurodisability. We have a brain injury service, which is our level 1 and level 2A service commissioned by NHS England, and patients who are admitted to our brain injury service on one of two pathways, either a prolonged disorder of consciousness pathway for assessment and disability management, or to our complex rehabilitation pathway for goal-focused therapy and input. We also have a specialist nursing home and specialist services, which are the Jack Emerson Centre, so long-term ventilated patients, the neurobehavioural unit, and our Huntington's disease unit. And one of our specialisms is working with patients in a prolonged disorder of consciousness. So both earlier on in their care pathway in the brain injury service and longer term in the specialist nursing home. A little bit about my background. I've worked here at the RHN for 15 years and I've been the clinical lead speech and language therapist on the brain injury service since 2009. And during this time I've developed a specialism in working with patients with complex neurodisability, including complex dysphagia, tracheostomy management, and those in a prolonged disorder of consciousness. And working with this sort of quite unusual rare population has helped me to consider which areas of clinical practice require further research from a clinician's point of view. And I was lucky enough to be awarded the RHN PhD fellowship at the end of 2018, which pays to backfill a proportion of my time so that I'm able to undertake a PhD to carry out some of this research related to our populations. So I started doing that. I'm currently in my second year part-time. I'm based at University College London, in the divisions of Psychology and Language Sciences, and my supervisors are Professor Rosemary Varley and Dr. Suzanne Beek. Okay. In this talk today, I'll give you a brief overview of prolonged disorders of consciousness and what they are, but I will be able to direct you elsewhere if you want more details on that. I'll be looking at how emergence from PDOC is currently defined and how we assess it as clinicians. And then I'll present findings from the first stage of my PhD, which was a UK-wide online survey that I carried out, looking at current opinions and practice when assessing for emergence from PDOC. And then I'll look at how we can use these, or how I can use these findings for the next stages of my research. So a brief overview of what a disorder of consciousness is. So following a severe brain injury, a patient might be left in a disorder of consciousness. And consciousness is considered to occur along a continuum. So at the lowest level, you'd have a coma. So there would be no eye opening, no sleep-wake cycle, and the patient would just be displaying reflexive behaviours only, maybe such as swallowing. If they move along into a vegetative state, you would then get periods of wake and asleep. So you'd have a sleep-wake cycle. There'd be times when the patient has their eye open, times when they're sleeping. It might not be the same as ours, so divided into night and day, but you've definitely got those sleep-wake cycles. There won't be any intentional behaviour. Patients might move around a lot, but behaviours are reflexive and spontaneous only. So you might see things like roving eye movements, moving around the environment, not focusing on anything, groaning, chewing, and purposeless movement of limbs, so moving arms or legs, but not actually towards an object or something in their environment. A patient might then move into a minimally conscious state, and in this state we do see a few responses. So they're inconsistent, but they're reproducible. So you might see things on more than one occasion, but just not every time you go and see them, and there'll be times when they can't respond at all. And more recently, this was divided into MCS minus, looking at sort of the lower level range of behaviours in these patients. So perhaps visual tracking of an object or person walking around the environment, or localising to a stimulus. So perhaps reaching out for something on a table in front of them, but perhaps not necessarily doing the right thing with it. And then MCS plus would be for those patients who are still very inconsistent, but demonstrating more complex behaviours, such as command following or attempts at a head nod in response to a question. So patients might move along the continuum of consciousness until they emerge into awareness, but they might just stay in a vegetative state or a minimally conscious state long term. That might be as far as they move. And a patient who has emerged is still likely to have a range of cognitive and language and physical impairments ongoing. They've still had a very significant injury. So disorders of consciousness are considered to be prolonged if they last for more than 4 weeks. So because I'm in a post-acute rehab setting, we just see patients who are in a prolonged disorder of consciousness, whereas earlier on in their pathway, people might see them when they're not prolonged, they're just a disorder of consciousness. So advances have been made in assessing using clinical imaging. So they're using things like functional fMRI to look at awareness for behaviours that maybe we're not seeing at bedside. So I've talked about some of the things we might see in patients, but sometimes using imaging we might pick up things that we're not seeing. But these are only still used in a research setting, and they can't be used with all patients at the moment. So as clinical teams, we are still really reliant on bedside assessments and inferring the presence of behaviour from what we see and what we observe within the patients. And determining that boundary between MCS and emergence is quite challenging. So you can see their emergence has been defined as the return of functional communication or the functional use of objects, and I'll go into that in a bit more detail. But those two things in themselves are just quite narrow, and that's one of the issues with how do we determine whether someone has emerged. Why is it important to get an accurate diagnosis of emergence? This is the bit that my PhD is specifically targeting. So if a patient is emerged but diagnosed as MCS, they might not have the same access to rehabilitation because we tend to target our resources at those with more predictable outcomes and where we will affect more change. It helps us if we have an accurate diagnosis and we know what someone is doing with prognosis. So if someone is emerged and they are showing high-level behaviours such as communication and using objects, their prognosis for further improvement may well be better. It helps give an idea of what their perceived quality of life might be. If they're able to communicate with family members, perhaps we might feel, or their families and team might feel, that their quality of life is higher than if they were at a lower level on that continuum of consciousness. And there is the potential that if they do demonstrate some communication behaviours, that either immediately or in the future, they might have the ability to at least participate in some decisions about their future care. Even if they don't have full capacity to make decisions, they might be able to express a preference. And this is where it's really important to get that accurate diagnosis, because until it might involve decisions about whether to continue clinically assisted nutrition and hydration, and looking at ceilings of ongoing treatment for people. So whether it's in their best interest to keep admitting them when they have infections to an acute hospital, or whether we treat them in different settings. So previously, family and clinicians had to go to court to seek to stop clinically assisted nutrition and hydration. But now if family and teams agree, it can be stopped in best interest and we don't need to go to court anymore. Also, it used to previously only be legally allowed to request if somebody was in a vegetative state. But this focus has very much shifted to away from that specific diagnosis of vegetative state or minimally conscious state to prognosis and the level of quality of life that someone might find acceptable. And should those that feed, that clinically assisted nutrition hydration be removed in a patient's best interest, working within the Mental Capacity Act. So it's vital that we get appropriate assessment tools and we get accurate assessment to best identify if a patient has emerged and perhaps to inform on what their future prognosis is going to be. So the current criteria for determining emergence were defined by Giacchino and colleagues in 2002. They're currently quite narrow and they require a significantly brain injured patient to respond with 100% accuracy. So to demonstrate emergence at the moment, a PDOC patient must demonstrate functional object use. So they've got to use 2 out of 2 objects in the right way on 2 consecutive occasions, or answer 6 out of 6 yes/no questions correctly on 2 consecutive occasions. This was extended a little bit by the Royal College of Physicians when they developed guidelines for PDOC patients in 2013 to include discrimination between 2 pictures or objects. So by discrimination, we mean spoken words, picture matching with 1 distractor. So for example, I might hold up a cup and a sock and say to the patient, show me the sock. And also to look at, they also introduced semantic matching. So holding up a cup and a saucer and a sock and asking someone to match the cup to the saucer rather than the sock. So in practice, a wide range of different stimuli and questions are used. So for example, with yes/no questions, you might have autobiographical, so is your name John? Abstract, so will a stone float on water? Situational, so this is what we might find in the coma recovery scale, which is one of the assessments that we use with this patient group. So am I touching my ear right now? And that's quite confusing because we're talking about right now or right ear, and what bit is the patient responding to? Or something like, are you in hospital? Which can be quite hard for patients because that overlaps with orientation. And we know that people that are in hospital long term sometimes find those questions a bit tricky. There's also limited guidance on what stimuli to use, what pictures to use, and sometimes guidance is a little bit confusing. So for example, in the RCP in 2013, some of the guidance was try using a cat and another animal, so items which are potentially visually and semantically quite similar, which might be quite hard for patients with a cognitive and or language impairment to discriminate between. So these criteria, we know that they're a little bit problematic. So patients who have a language impairment risk misdiagnosis, especially if they're physically impaired. So often we see patients whose upper limbs are quite flexed, quite tight, high tone, they're unable to use them to demonstrate object use. So they're reliant totally on language ability to be able to indicate whether they've emerged or not. And there was a group, so Schneekers and colleagues in 2015, they took 24 stroke patients with different types of aphasia. So just a focal injury, most likely leading to a language impairment, specifically not a disorder of consciousness. And they carried out the Coma Recovery Scale Revised, which is again one of the PDOC assessments. And they found that 3 patients with global aphasia did not meet the criteria for emergence and would have been diagnosed as being in MCS, so still in disorder of consciousness. And then Nakazi, Richardson and colleagues also found that patients who weren't in a disorder of consciousness but who had a severe brain injury were more likely to give inaccurate answers to yes/no questions, so up to 22% of the time. So simple orientation questions, 22% of the time they'd be getting them wrong. Situational orientation questions, 31% of the time they'd get them wrong. And judgment questions, so will a stone float, 39% of the time patients were getting them wrong. And I think a range, like I said, a range of stimuli and tasks are used in practice. And bearing in mind some of these issues, I think clinical teams sometimes find it hard to demonstrate emergence working within the criteria that we currently have. And I think teams often work with patients who they just really don't feel are in a disorder of consciousness, as they demonstrate awareness, they demonstrate a range of behaviours, but they are either unable to demonstrate them with 100% accuracy or the specific behaviours needed to meet the current criteria. So having worked with this population and thinking about this and working with sort of other team members, I decided to have a look at this as the first part of my PhD. And I've carried out an online survey with the aim of establishing the opinions of expert clinicians on the criteria and tasks recommended for determining emergence from PDOC. And a massive thank you to any of you who might be listening today who've helped me with dissemination of that questionnaire, that survey, or filling it in. And my aim was to look at how is emergence determined in practice by experienced teams, and to help me then identify current issues and define objectives for the next stages of my research. So I wanted to send the survey to people that I knew were experienced in assessing for emergence in particular, because it's one part of that continuum. So I'm very aware that clinicians and therapists see patients emerging from disorders of consciousness in other settings, but they might have different priorities. So in the very acute setting, it might be medical stability, and people might move very quickly through that continuum as they spontaneously recover. And I'm also aware that people also emerge in continuing care in nursing homes, and I didn't look at those because there are tend to be fewer staff members actually assessing those patients. So it's not currently easy to identify which post-acute settings take PDOC patients when they're discharged from acute hospitals. So I made a start by looking at the UK ROC, which is the UK Research Outcomes Collaborative list of level 1 and 2A settings in England. So these settings will admit the most complex and severe neurological patients, but it's not easy to work out whether they admit PDOC patients. And then Wales and Scotland are even trickier because even that list doesn't exist. So I had to send freedom of information request to all of the 26 health boards in those countries to ask them, where do your patients go? So I was able to identify 33 potential sites by doing that. And I wanted to then find out which ones of those regularly admit PDOC patients, so that they've experienced staff members and they've experience with assessing for emergence. So I defined that as centres which admit at least 3 patients a year in PDOC for the past 3 years. But to identify that, I had to hit the phones and do a lot of cold calling to try and work out whether those centres admitted those patients. So I tended to go for SLTs as contacts because that's my background, and I know that SLTs tend to be lovely people, and once you get through to them, they're really helpful, and everybody that I spoke to was really helpful. They agreed to help disseminate my survey to their multidisciplinary teams, and also to let me know how many people that they had sent it out to. So by doing that and by establishing those contacts, I could find 15 centres in the UK that regularly admitted PDOC patients for assessment out of the acute setting. So I then devised and sent out a 31-item pilot tested survey, which I distributed electronically. And the questions were devised using literature, the guidelines that exist, and sort of clinical experience of myself and of the small team around me that helped to pilot test the survey. The survey was open for 6 weeks between March and April 2019. And I had a response rate of just over 35%, which is quite favourable. And I was able to work that out because the SLTs that disseminated the questionnaires for me were able to tell me how many people in their team they sent it to, and I could look at how many responses came back. So I analysed data from 75 respondents, looking at different areas that the survey probed, so background information about the respondents, their confidence in diagnosing emergence, and how functional communication specifically is assessed, what their thoughts were on the use of formal assessments, their opinions about the current criteria, and how assessments are used to determine emergence, and how they include family in assessments. So it was quite a quick survey. I think it only took about 10 minutes, hopefully, and it was a mixture of closed and open questions, which I analysed using descriptive statistics and thematic analysis. So just over 81% had worked with PDOC patients for more than 2 years, and almost 83% were working in centres which admitted more than 5 PDOC patients a year. So this showed me that my survey had reached those clinicians that I was aiming to get to, those who are highly experienced accessing emergence from PDOC. 41% reported that they were confident that the current criteria and tasks would detect emergence. But note that on the third line here, only 21% were confident that the task would detect the return of functional communication. And the really large majority of patients, almost 80%, worked with patients that they thought had emerged, but they couldn't demonstrate it using the current criteria. And then they were asked what they might do with this. So if patients were responding, but they weren't responding accurately, not 100%, you'll see that about 23% would define them as MCS, some would define them as emerged, some would just describe what they were doing, and others would use another term, emerging. So throwing up some sort of inconsistencies and perhaps a lack of guidance on what to do with patients they're not meeting criteria. So respondents were asked in an open question, what would they do if they thought a patient had emerged but they couldn't demonstrate it? And 4 clear themes emerged. So they would either continue assessment, and they would often continue, but with attempts to personalise assessment and trial different technologies, perhaps to be more motivating or to promote different access for patients with motor impairments. Or they might use different functional contexts, such as oral trials or assessing with the family present. So they would keep looking, basically. They felt that there was something going on with these patients. They were no longer in a disorder of consciousness, but they needed to find another way to try and demonstrate it. Other people would try and address additional underlying problems, so either medical instability or in particular perhaps looking at other issues such as language impairment or apraxia and trying to accommodate or alter assessments to try and compensate for some of those difficulties. If they thought the patient had emerged but they couldn't demonstrate it, they might look at how they would negotiate a team decision. So thinking back to that last slide, how would you define somebody if they hadn't quite met the criteria, but you didn't really feel they were still in disorder of consciousness? And there was an impact of this. So there's no clear guidance and people would tend to negotiate. Sometimes it might be MCS, sometimes it would be emerged. But actually there was an impact and people talked about this uncertainty. So one person said, I don't know what to do. I don't know what to do in this situation. And a couple of other people commented on the impact of perhaps being pushed into making a diagnosis to do things like secure continuing healthcare funding. If they were still in PDOC, then this is considered to be a priority. So 54% of respondents reported that they observed behaviours that they thought indicated emergence, but were not currently included in the criteria. So they were asked to give examples of behaviours that they thought might indicate a high level of consciousness or functioning. So many looked at wider communication abilities. So are we looking at verbalising? Are we looking at consistent responses to command? Many looked at sort of broader behaviours, so eye contact, gesture and command following. But these are usually associated with MCS, so lower level behaviours. And even though command following seems higher, there was a study in 2015 by Osborne and colleagues who found a dissociation. So a patient can follow a command, so for example, to give a thumbs up, but not use it spontaneously in communication. And we often see this, I've often seen this in clinical practice, where you get patients doing things, and then you desperately say, okay, show me a thumb up when you see a picture of your mum, or can you use it for yes? And then they just can't do it. So they're doing it because you tell them to, but they can't use it functionally. That's why it's currently an MCS behaviour. So people were looking at emotional responses, so laughing, smiling at a joke appropriately, looking at appropriate responses in functional tasks. So can somebody differentiate between different tastes, something they might like, something they may not have liked in the past when they're having tastes. And also looking at less than 100% accuracy. So quite a few people commented on this. And patients in PDOC have had a really severe brain injury, and it seems likely that they're going to continue to have a range of cognitive and language impairments, even if they are emerging or they've emerged, and that they are unlikely to reach this 100% score, because there'll also be other complications such as fatigue, poor positioning. So that seems to me quite a high bar to set. But lots of people would actually say, okay, I'm going to accept less than 100%. So not actually going along with current guidelines. Clinicians also thought that differentiating different people was a really clear behaviour, that someone was doing something of a higher level, particularly with families and responding to family members in different ways. And there is evidence that there are improved responses with familiar people. And then there were some clinicians that looked up perhaps lower level behaviours, so maybe localising or tracking. But these ones, but it's quite clear from the literature that some of these behaviours are not cognitively mediated. But overall, what it does demonstrate is that clinicians and teams out there working with this patient group and trying really hard to look at, are these patients emerging? Are they showing us that they can do more? We're trying to look at breadth of behaviours, and they're sort of finding that the specific and currently recommended tasks and criteria aren't quite enough. There's something else, that they're looking for something else. So when asked about the currently recommended tasks, 100% of respondents used yes/no questions, and all of them were confident that they could carry out that task and support a patient to participate. So the discrimination of 2 items, so remember that holding up the cup and the sock and show me the sock. So the spoken word to object match with a distractor. That was used by almost 90%, and 97% were confident that they would know how to carry out that task. So the semantic matching task, so the cup matching with the saucer or the book, was used by 55%, and people were less confident with being able to set up and manage that task with patients. So just over 70% were confident. And if you compare that sort of the yes, no, and the discrimination, where really the vast majority are confident. And about 30% didn't feel that they could choose the stimuli appropriately. So they couldn't choose those which were phonologically, semantically, and visually dissimilar to give patients the best chance to respond. So picking things like cup and sock, which sound different, look different, and are from different categories of items. So they were asked about actually what do they use, what things do they use for the different tasks. And the most common items were objects, pictures and colours. So these are items which are easily available in the patient's environment, and they're also quite concrete, quite easy for people to maybe to see or to be helped to feel if it's an object. And colours could facilitate a response in people who perhaps have visual impairments, visual field neglect, or acquired visual impairments due to their brain injury. Biographical and situational yes/no questions. Biographical and situational stimuli were used for yes/no questions the most. So situational, remember, that's the am I touching my ear right now? That comes from one of the assessments. So again, from people who are working with this patient group will automatically try and use those questions. Also biographical, because we know patients might respond better to familiar information. So what we're finding is people are really trying to personalise and try different things with patients. Some of the things that are recommended are a bit trickier. So things like sound. So even though there's quite a high level of visual impairment in these patients, setting up things like pairs or discrimination of sounds is actually quite tricky, and it's not used as often as perhaps it could be. So there are 3 main formal assessments that are used with assessing patients in PDOC. There's the Wessex Head Injury Matrix, the Coma Recovery Scale, Revise, and the SMART. So the WIM, just for those who may not know, I haven't got a lot of time to go into detail here, but the WIM is a hierarchical checklist of behaviours developed in patients post-ABI in an acute setting. The SMART and the CRSR have been developed specifically to assess for patients in disorders of consciousness, all the way from vegetative state through to emerging. And they tend to provide a stimulus to one modality at a time, one sensory modality, so visual information, auditory information, as well as assessing for communication and other behaviours. So you see that the three formal assessments were used quite widely amongst respondents in looking at emergence. So the WIM was used most, and the CRS, and then the SMART. A few people use other assessments. So there's the MATDOC, which is a music therapy assessment, and the STAR, but those are less wide circulation. So although these assessments were quite widely used, you can see that there's a discrepancy because the confidence in their ability to contribute to the assessment and detection of emergence was much lower. So the WIM was the most well used, with 91.7% of people using it. People were least confident that would help to assess emergence. So it wasn't designed as a PDOC assessment, and it allows for assessment on a whole range of behaviours, which could explain its most widespread use. But I think perhaps some of the items on it don't reflect the current emergence criteria specifically. So it's quite hard. If you want to assess somebody on emergence using the WIM, you have to sort of go outside what's on the assessment. So the coma recovery scale revised was the second most frequently used, but again, not much sort of low confidence levels in how it would detect emergence, which perhaps is a more surprising finding because this assessment was developed by Giacchino and colleagues who proposed the current definition of emergence, and the assessment itself incorporates the specific criteria of object use and yes/no situational questions. But it could be its lack of confidence and is to do with that lack of flexibility. So we've seen that people feel that people might have emerged, the current criteria don't reflect what they're seeing. Actually, that assessment keeps them stuck to those particular tasks. And then the SMART was used a bit less frequently. It does require sort of specific training, unlike the others, which you can train sort of in your own setting. But also it does have wider range of behaviours, perhaps things like cause and effect with an auditory feedback switch, which potentially clinicians might find more useful in contributing to assessment of slightly higher level behaviours. Overall, I think what the respondents were showing is that we haven't got enough assessment. The assessments aren't doing what we want them to do. We're using them, but we're actually not confident that they're doing what we need them to do. They're not finding what we want them to find. They're not showing us, they're not useful in showing us whether or not a patient has definitely emerged from a disorder of consciousness. So I then asked about the benefits and challenges of involving families, specifically in how we assess emergence, and assessing functional communication in particular. And the majority of respondents did involve families in assessing communication, but it was usually in a support role. So they were observing a session, they were providing background information, so about a patient's likes and dislikes, and they weren't administering or taking part in administering the tasks themselves or presenting the stimuli themselves. So it was much more of a support role. And when respondents were asked, what do you think the advantages are? Three key themes came out. So it improves assessment because patients are more likely to respond to family members, and then things, supportive role, like they can sometimes use the patient's first language. It provides an opportunity for education. So if you're working alongside a family member, you can demonstrate what the patient's doing, why they're doing it, and also importantly, what they're not doing and how they might be interpreting a behaviour that you're interpreting differently. And then the other theme was about providing the family with a role. So again, it's spouses of PDOC have been found to identify really strongly with that caregiver role when they're unsure of how to help. So Giovanetti and colleagues found that in 2015. So they want to be a caregiver, and they don't know what else to do, that the previous relationship with their loved one has changed. But some of the clinicians who responded did feel that this altered how someone might spend time with their family member, which could be detrimental. So although it provides a valid role, we'll see when we talk about challenges that also people felt this wasn't always a good thing. Okay. So looking at challenges revealed 5 themes. So I think working with families, clinicians felt that families sometimes overestimated patients' abilities. And I know that I've seen that in clinical practice myself. So for example, if a patient has a muscle spasm in a hand or they're blinking, it might be interpreted as being used for a yes or a no, or I don't like that. This can sort of quite often place a strain on that sort of clinical clinician-family relationship, because you're looking at one thing from different angles and trying to interpret them differently. It might prevent objective assessment. So, for example, they felt that if families were involved, they might stimulate patients too much, they might bombard them, they might really want them to respond. So I know that I've been in sessions where you would present a stimulus to a patient and you're giving them time to respond, you want to see what they do, but the family member jumps in and they prompt or they encourage, where actually you just want to see what the patient's doing. And I think that sort of difficulty sometimes that families have was also commented on about how they cue patients. So if they are involved in presenting the stimuli or talking to patients to try and facilitate behaviours that you can assess, how do we get them to slow down? How do we stop them cueing if you're showing them objects? And I think some clinicians felt that it's really hard for families to do that. So involving families, some clinicians here thought that it would have a negative impact. So they lose their role, so they're no longer carers and they become assessors, a slightly different role. So that's sort of perhaps assessing, and then when the therapists aren't there, continuing to assess patients and ask them questions rather than just enjoying being with them. And I think there was some comment there that some families find it too difficult and they don't want to be involved, perhaps because they're not ready to see the level at which their loved one is now able to function. On the previous slide with benefits of family involvement, we saw that education of families, it was really valuable. But on the flip side, respondents were also highlighting that this took a lot of their time. They might need to be prepared beforehand for sessions, explain what we're going to do, probably debriefing afterwards, and training of families of what to look for. And then the impact on the relationships. If you're not seeing the same thing, to involve families, you have to have that sort of open and honest relationship. Families might disagree, and then you might end up with sort of mistrust or compromise. And I think that has an impact on clinicians, but also on families. So I've asked clinicians about what they think the benefits and challenges of family involvement are, but at the moment we don't know about the views of family members, which would be a really interesting piece of research for somebody to do, particularly looking at emergence and that return of communication. What do they think about it? How do they want to be involved? So overall, the finding of the survey, when I analysed them, have highlighted how current practice aligns with our existing guidelines. So there are a range of professionals involved in assessing emergence. So I had responses from doctors, physios, occupational therapists, speech and language therapists, psychologists. But the recommended tasks are used, and we know that they're used. So the yes-no task was used by 100% of respondents. The recommended formal assessments are used, and families are involved, and diagnosis is established by the whole team. So I think diagnosis was team-based for 98% of respondents. But what I also found is that practice sometimes diverges from our current recommendations. So people use, about a third of respondents use a range of tasks and stimuli other than those currently recommended. Clinicians often consider a wider range of behaviours than those recommended. And some respondents accept responses at less than 100% accuracy and will take that still as determining emergence. and most were not confident that the current task would detect the return of functional communication. And then specifically the matching task, so that cup, saucer, with the sock task, was only used by about half, and a quarter of respondents reported they didn't know how to carry it out. So what do we do next? So a review of the current criteria and tasks would be useful. Clearer guidance for people about choosing appropriate stimuli, given that we know about a third were not confident that they could. There's all sorts of tasks and stimuli being used, and there's potentially a need for standardized resources based on psycholinguistic principles, so guiding people so they know that objects they use look different, sound different, and are not in similar categories. Clearer guidance on what to do with an uncertain diagnosis. And at the moment, I know that teams often sit and discuss patients who are on the border. They're not quite sure what to do. They feel that they've emerged and they just don't know what to do. And to establish how family can optimally be involved in specific assessment of the return of communication. So what next? So the RCP guidelines, the Royal College of Physicians guidelines on PDOC, were updated earlier this year. And I was able to feed in some of the results of the survey. So that matching task has now been removed because we felt, I think, as a group and following the feedback that everyone who filled out the survey gave, it wasn't actually very helpful in determining communication. It perhaps looks at a cognitive, it looks at a specific cognitive skill, but not communication per se. And we've also given in the Emergence Annex a bit more guidance on choosing appropriate stimuli. So as I mentioned before, that cat versus another animal has been updated to give people much more guidance on how to choose appropriate stimuli. So using the findings of the survey, I'm going to move on with my research and look at what I can do next. So I'm going to look at yes, no, and discrimination tasks with a specific set of stimuli with a group of about 30 patients emerging from PDOC. So I'm going to use colours and objects and the situational questions from the coma recovery scale. So am I touching my ear right now? To look at yes, no questions, and also the discrimination or the spoken word to object match. And then I'll compare which stimuli and tasks are emerging patients most likely to be accurate with. But also compare myself presenting those tasks with a family member to look for if they're trained to specifically assess for emergence, do you get a different response because it's a familiar person presenting the tasks. And then following that, we're looking at the other key area that respondents reported was looking at lots of behaviours in context, different responses to different people, emotional responses, perhaps laughing appropriately. So also the next stage after looking at specific tasks will be observing emerging patients in context to look at is there breadth of behaviours that they are displaying that we're missing just by focusing on specific tasks in therapy sessions. Okay. So before I finish, this slide really has lots of ideas and places to go to find out more information. The first link is to the survey written up as a paper if you want to read a bit more about my findings. But there's also the links to the updated Royal College of Physicians guidelines, so that will give a lot more detail on what is vegetative state, minimally conscious state, and how we work with and assess these patients. I've put in a link to the Putney PDOC toolkit. So that was a practical kit that myself and colleagues put together to look at providing resources for assessment outside of the formal assessments that we use. So there's some guidance there on assessing emergence, monitoring object use, and personalising programmes. And then using some of the information from a paper written by Hannah Roberts on SLT practice with PDOC patients. A group of us have written some specific SLT guidelines for adults in a disorder of consciousness. And again, there's a link to those, just that's profession specific to guide SLTs in particular with how to work with these patients. Okay, so I'm going to ask for questions. I think, Anna, if you've been putting them on, adding questions on chat, Anna can send them to me.
Yes, so we've had one question. So if anyone would like to submit any questions, do submit them to the Q&A section just at the bottom of this webinar screen. We've got one question that says, were the 20% of respondents, Amy, who hadn't worked for more than 2 years or didn't see more than 5 patients per year excluded from further analysis, or were they included in the
No, they were included. No, they were included. But what it was just showing me is that the majority were experienced clinicians, which is the group that I was going for. And some of those with less experience might have been in quite specialist centres with lots of support and experience around them. So they weren't excluded at all. They were definitely included.
Okay, I've got another question. Was the profession of the assessor considered or documented?
Not specifically. We had a range. I didn't go into a lot of detail because I started off with 75 respondents who started the survey. There were 2 drop-off points. People who didn't assess emergence could drop out, and then people who didn't assess communication at a later point could drop out. So towards the end, there was a bit more of a slant towards SLTs and perhaps OTs, who tend to be more involved in PDOC assessment and communication assessments. But the ones dropping out earlier on were the physios and the doctors. So that's I didn't analyse any further than that because the numbers weren't so great.
Okay. We've got another question here. Which assessment did you use most regularly? And how do you identify which is the most appropriate for an individual?
Me, a clinical question. I think that's a really tricky question in this context, that's all. It's a big question to answer. Here at Putney, we use the 3 assessments. We use the WIM, the Cone Recovery Scale and the SMART. We tend to start people with the WIM because it's a checklist. It's quite easy. They come in, we can see them in bed. You can gauge an idea of what level they're at and what you want to do. And then we'd look at, well, then do we start using the CRSR? Do we start using the SMART, depending on their need? The updated RCP guidance want people to start using the CRSR as a go-to assessment because that's what's used more internationally and for research purposes. So if you're going to choose one, I would definitely go for one or the other. I think if you're in an acute setting, the WIM might be more useful because it's just more flexible, and I know what the acute setting is like. It just depends where you are. But have a look at the updated RCP guidelines. But out of those 3, but also like I was saying, there's others out there. There's the STAR, which has been developed at the Central England Rehab Unit, and then there's other ones like the MATADOC, which music therapists carry out.
Okay, thank you. We've got a message from Julie. When you mentioned the assessments aren't doing what we needed, what barriers were there?
I didn't ask that particularly. Let me just go back to my slide. I didn't go back to that in particular. I didn't ask that particularly. I just asked about confidence in specifically assessing for emergence. So I don't have an answer to that. It would have been interesting in hindsight to have put that in. Why are you not confident? But I think it's sort of clear that they're all being used, but particularly for emergence. And it might be that they're more useful when you're trying to distinguish lower on that down in that continuum. Is somebody the S or the MCS, or what MCS behaviours are they showing? But it's just that specific bit of emergence they're perhaps not confident in.
Okay. I've got an interesting question here. How might you assess phonological discrimination in visually impaired patients in PDOC, i.e. do you need a consistent hand squeeze, etc.?
I've never assessed phonological discrimination. I think going down to that level with such a severely impaired, brain injured patient, you want it to be much more functional. So I don't, but if you were, you would want a reliable response. So, but if you've got a reliable response, you know they've emerged. So therefore you're moving on to assessing a specific linguistic or cognitive domain rather than a consciousness as such.
Okay. Have any units reported making their own standardised PDOC assessments to accommodate for items that other formal assessments have missed?
No. They were allowed, so with the questions about what assessments do you use, there was always an other box, and that's where I had the STAR and the MATADOC mentioned. But I think clinicians, because we have the RCP guidance guidelines, I think people we have quite a standardized approach to these patients. We use that very much. So no, nothing as yet, but obviously with my research, my long-term future aim, and these things do take quite a lot of time, is to look at how we're assessing emergence in particular, and do we need a specific assessment for that we don't have at the moment.
Okay. We've got a question from Eleanor. She asks, Amy, are you aware of gaze viewer? Has this been used in the assessment of PDOC?
Does she mean eye? I don't know what gaze viewer is.
Might be eye.
Does she mean eye gaze? Do you mean eye gaze? I don't want to talk unless. Do you mean eye gaze, Eleanor? Quick yes, no.
Tell you what, we'll see if she comes back. And just moving on to a next question. Yeah. For the next part of your study, will you be recruiting new clients, or will you go back to the old for your research?
No, I'm going to be recruiting whoever comes into RHN that I can get my hands on. So it will be in the brain injury service, definitely new clients, because they're going to be emerging. They're going to be patients that their clinical teams are saying, right, we think they're emerging now. So I'll have a 3-week window to work with them. So on the brain injury unit, there'll be new patients. But also in our specialist nursing home, we have patients that do emerge. So again, if they're emerging at that point in time, so some will have been with us but may not have had input for a while, and they change, or some will be new to us.
Okay. I've got a question from Siggy. She asked, what's your opinion on the use and limitations of Zoom sessions for patients in PDOC and family members, given COVID-related restrictions, like regarding visiting?
Yeah, that is a good question. I mean, it's really valuable, because if so for example, I know that here on the ward, we're not having any family visits at all. So we've been facilitating Zoom sessions with the family. So we're carrying on with our assessments. So we might still be doing and scoring WIMs and CRSs or personalised programmes, but we would very much bring family members into some of those sessions on a Zoom to see if you get a difference in response. So you've got familiar voice, you can see a face. I think it's possibly trickier to set up more specific assessments, but definitely bring them in. Hope that answers the question.
Okay, thank you. Eleanor's come back to us. So gaze, it's a software which plots the gaze of a client on a screen. You need eye gaze camera to use it, but it's not eye gaze.
Right. So I imagine we do. So what we're really lucky here. We have the Compass technology team. So if I need to put a patient in for eye gaze, they would probably do that and look at plotting. And I think what you might be talking about is, so they following, but that would be potentially lower level behaviour. But it would be really useful if you could then go on to use those eye gaze movements for those tasks. So can they look at a yes, no? Can they look at the cup or the stop on a screen if that's more accurate for them and that's the only behaviour they have? I'm not going to be able to answer that very well here. If you want to email me and we can have a chat, it might be more useful, just because it's not my... We do use eye gaze. It's not always successful with PDOC patients just because of the massive complex impairments they have, visual, head support. But there are some patients, particularly... I've worked with MCS sort of plus patients who are doing things, and you just think, is it because they're really bored of me showing them pictures and they need to be, is there a motivation in using a computer, or is it really going to catch something different?
Okay.
But we can have a chat maybe if you want to email.
I've got a question here. Just wondering if there's any guidance on family involvement currently that you could signpost. This is from Grace, that you could signpost Grace to.
I think, Grace, if you have a look at those links that I've written, there's stuff in the RCP guidelines, definitely, and there's bits and pieces in the speech and language therapy guidelines if you're a speech and language therapist. If not, read them anyway. And how to involve families. You can involve families. They should be involved in assessment. It is really important. There's more and more evidence that patients respond differently with family present. There are some pitfalls that were highlighted as well with how families might interpret, but it's really useful. But there's nothing specifically on how to involve them in assessment of emergence, but there's stuff out there about how to involve them.
Okay, thank you. We've got a question from Orla. Outside level 1 or 2A units, do any other MDT teams make formal diagnosis of PDOC patients?
Yes, they do. They will do in acute settings, and they will do in nursing homes. I think I know of colleagues that go into nursing homes longer down the line and they carry out assessments and they will make diagnoses with their teams there. It might just be a matter of trying to gather that team and to find the right expertise. But again, the RCP guidelines do have information on what you should be doing along the care pathway. So acute, rehab, and then longer term.
Okay. And a question from Rebecca here. Are you aware of any PDOC assessments for children? And if so, do you know the age ranges?
No, is the short answer. But I'm pretty sure I'm going to name them because I know some people are listening in from the Children's Trust, and I know that at one point you were looking at developing a WIM for children, and it's possible that the SMART is, I think there was some work looking at the SMART for children, but obviously we only have adults here, so it's not something I've worked with, but definitely perhaps worth getting in touch with those colleagues because they're more likely to know how far along the line those assessments have gone.
Okay.
Sorry, can't be more helpful with that one.
And I think just time for a final question. What are your top tips for working with patients in PDOC that you think other centres or acute centres should know and work towards?
Top tips. Okay. I guess being thorough, questioning everything all the time, like what are you seeing and why? And if you're not seeing anything, why is it? Is it because of their level of function, or is it because you're not doing anything that's interesting enough or personalised enough? Not being constrained by formal assessments, and always being honest and open with families, I think, is my biggest top tip, because working with families with this patient group is such a crucial part of what we do, because it's a really traumatic time for them, and you need to be working together to educate, but also you really need families to tell you about this person in front of you because they can't tell you anymore, and working with them to look at what would be interesting to them if you're doing all these assessments. And I think just personalising everything and spending time getting to know who this person is. Again, that's quite vague, but there's lots of guidance out there. If you have a look at, if you're an SLT, look at the SLT guidance. There's tips there about trying different things, so sort of thinking outside the box slightly, so using taste trials, even though that's not one of the emergence criteria, giving people things they might like to eat, not like to eat, if you're an SLT, and just seeing it and just trying lots of different things with people.
All right. Well, Amy, I just want to say thank you so much for presenting. I hope everyone's found it really interesting.
Thank you.
We've been recording this, so we'll put it on the website, so it'll be available afterwards, and we'll see if we can circulate the presentation as well. And we hope people enjoyed it. Thank you for joining us today. We'll be running another open lecture next week, so feel free to join us again. Thank you.
Bye.